Listening to Eve's fluid therapy webinar with Dr. Clifford Hawley. Clifford graduated from the University of Melbourne in 2009 and spent his first 3 years in general practice. In 2013, he made the move over to emergency and critical care, where he completed an internship. Since then, Clifford has worked almost exclusively in the emergency setting and obtained membership in the Australian and New Zealand College of Veterinary Scientists in 2014 in ECC. So welcome, Clifford. Thank you for joining us today and allowing us to interview you on fluid therapy.
Thank you for having me.
Thank you. We appreciate this because fluid therapy is obviously something that we do every day for vets, junior vets and nurses, and it's a complicated topic, and I think it can be quite daunting. So I've recently done a fluid therapy webinar, which is available on my website. And essentially this interview is going to complement that webinar. So we're going to talk through some subjects, and I'm going to ask you some questions in order of kind of the information given on the webinar, so that we can try and put your practical knowledge to some of the more textbook theory of the webinar. Okay. So first of all, let's start with a really easy kind of open question. What is the most common fluid used in, do you think, emergency practice?
Yeah, so isotonic crystalloids are by far the most common types of fluid we use. The one we tend to use the most is lactated ringer solution, or LRS. We generally use this over other solutions such as 0.9% sodium chloride, as it is a balanced solution with a composition similar to that of blood plasma. So we use it to correct hypovolemia, the replacement of dehydration in our patients. And although it is a replacement fluid, we commonly use them as a maintenance of hydration because the patients can excrete electrolytes that they don't necessarily need to use.
Okay, so when you call it a balanced fluid or a balanced solution, you essentially mean it's got the same electrolytes in it as plasma and is very similar to the body.
That's right.
Okay, and talking about sort of using, I do talk in my webinar about using replacement fluids, so LRS and 0.9% sodium chloride, as maintenance fluids, and there is a difference there, but like you said, patients are not often switched to maintenance fluids, and they're often just kept on rehydration fluids or replacement fluids, aren't they? That's kind of what you're saying there, and LRS and such can be used as that.
Yeah, so the body's pretty dexterous in what it can do, and for animals with particularly normal kidney function, and they're able to regulate their own fluids pretty well. So that's why we don't always change over to what we can call a maintenance fluid instead of a replacement fluid.
Yeah, so if they were kept on LRS and there was a little bit too much sodium in there, the patients, as you're saying, could excrete it. It doesn't really cause too much harm. Generally, it's pretty safe.
That's right.
Okay. If there was anything there that you are unfamiliar with, or we're talking about kind of the maintenance fluids and you need a bit of a refresh, there's always the opportunity to go to the webinar part of the website to be able to watch that webinar currently for free. So quite quickly in the webinar, I start talking about hypovolemia and bolus fluid therapy. So this is obviously something that I think you have to do quite often in emergency. How often do you think that is, that you need to actually provide fluids to a patient via a bolus method?
Yeah, so pretty much any patient that presents in shock, except for cardiogenic shock, will receive an isotonic crystalloid bolus. So the fluid volume can be titrated according to a patient's needs and intravascular volume deficit to avoid complications and fluid overload. Okay,
yeah, so it's also referred to as a fluid challenge, isn't it? Which I think is a very good term, because it's volume dependent, so you give a set volume and you see how that patient responds, correct? And then you can give more.
So you give a fluid challenge and then you reassess their parameters and you decide if they need another fluid bolus or if what you've done is adequate for that patient.
Okay, yeah, and that is instead, as like you say, the old shock rates, which for a dog was 90 ml per kilo per hour, so quite a lot, and it would go over that hour. So you are saying, yeah, you give it in a shorter space of time and keep more of an eye on them rather than put them on that longer rate.
Yeah.
Okay. Can you give us some rough dosages as a guide? Like if a vet was listening and sort of struggled with making that decision about how much fluid to give. I think some get a little bit worried about high fluids in kind of mil per kilo.
Yep. So it's not a set number. In dogs, you generally use about 10 to 20 mil per kilo, and in cats, about 10 mil per kilo. I usually give this over a 10-minute period.
Okay, so yeah, 10 to 20 mils in a dog, 10 mils per kilo in a cat, say. And a big question is, when do you know when to stop a fluid therapy bolus? Like, when do you know enough has been given?
So in general, you keep giving boluses until you reach a predetermined endpoint of resuscitation.
Okay, well, that's a point I wanted to raise as well. So what is an endpoint of resuscitation?
So the goals and endpoints of resuscitation are primarily based on the physical exam. Usually these patients present in signs of shock, and that's why we're giving them the bolus. Signs of shock include the mentation, the heart rate, the gum colour, the capillary refill time, and pulse quality. The endpoints are goals we want to reach with the fluid therapy, and we wanted to monitor for improvements and offer normalization of these parameters.
Okay, so yeah, so we want to, what you're saying is we want to keep giving the boluses and keep giving the fluid until the abnormal parameters they present with start to return to some normality. I've definitely done that as a nurse. You know, dogs have presented shocked, tachycardic, and we've given the fluid and we've seen that heart rate come down. We've seen a bit of pinkness return to the gums. The mentation has improved. So yeah, so you're just following that. That's a guide for knowing you're on the right track, I suppose. How do you monitor these patients in your clinic then when they first present, and then how do you monitor them through that fluid bolus?
So mainly just with a stethoscope and by clinical exam. As we mentioned before, most of these things are the vital signs that you're picking up with your eyes and your ears. It's also, you can definitely hook them up, and it is a good idea to hook critical patients up to monitoring equipment, as this can provide constant information readily. So we have a multi-parameter machine that we connect them up to. This will have blood pressure, ECG, oxygen saturation, if need be.
Yeah. And I suppose that's the role of the nurse, really. So as the patient's presented, put on the table in front of you, you're doing your checks, and the nurse is kind of hooking that equipment up. So you've got your own eyes and ears, and then they're hooking that up, and you've got that secondary bit of information.
That's right.
Okay. And do you verbalise these endpoints of resuscitation with your nurses? So, do you give them endpoints to look for, or do you actually watch the patient yourself?
Yeah, so, the nurses where I work are, great at what they do, so they're very used to these things. So in my situation, you don't often have to verbalise it directly. But in the general sense, the nurses are your eyes and ears, and you might say something like, give a 15 mil per kilo bolus over 10 minutes, and then the nurse would repeat the vitals and TPR. And if some of the vitals are still elevated, we might say administer another bolus if our endpoints aren't reached.
Okay. While we're talking about nurses, do you have any other expectations of nurses during this kind of monitoring period or this time?
So I do expect them to know what normal and abnormal is. Things like knowing what the normal heart rate should be, getting a grasp of the pulses, normal gum colour, and capillary refill time. The only way to get a feel of these parameters is to take the parameters on both normal and sick patients and really taking note and thinking about some of the signs we're seeing, because we do them not just to fill out numbers on a chart, it's because they have significance to the patient.
Okay. Do you ever worry about overloading a patient on fluids?
Yeah, so giving too much of any treatment can be detrimental. Excessive fluids can cause edema, particularly pulmonary edema. Also, dilution of the contents within the blood, such as the red blood cells, blood protein, and coagulation factors, can also be detrimental.
Mm-hmm. Yeah. It's certainly something, as nurses we worry about as well, and, being careful on the monitoring and things, I think is good for nurses to be pretty stringent with. Are there any examples where you would administer either judicious fluids or even no fluids at all, any patients?
Yeah, so some primary examples of patients with heart conditions, where they're particularly prone to fluid overload and pulmonary edema. Another one would be haemorrhaging patients and those with pulmonary contusions, which is bleeding into the lungs, which is usually after things like road trauma. If you give too much fluid, you will cause further bleeding and can also potentially worsen pulmonary contusions, resulting in respiratory compromise.
Mm-hmm. So would you consider just lowering the bolus amount for these, like say your dogs where you suspect there are pulmonary contusions, or?
Yeah, so you might use something on the lower end. So rather than a 20 mil per kilo bolus, you might give something like a 10 mil per kilo bolus and reassess more frequently.
Okay. Yeah, that makes sense. One thing I mentioned on the webinar as well is non-responders to fluids, which they do crop up every now and then, where you do get patients and they just don't respond appropriately to the fluids we're given, which I think, as you said before, is an experience thing as well. And, you know, I've definitely seen nurses that pick up on this and then go back to the vet and say, hey, you know, I just don't think this one's shown the improvement that it probably should, given the fluids it's had. Do you see many of those non-responders?
Well, so in relation to patients that are in cardiovascular shock, there are several causes of this. Patients which are hypovolemic should respond to the fluid therapy. However, there's some patients that have, say, anaphylactic reactions or septic shock and have a form of what's known as distributive shock, where the blood vessels are dilated and won't constrict as they normally should. These often require both fluids and medications such as vasopressors like noradrenaline.
Yeah, sure. But so it's really important that we do obviously see them, because surely if they have had any kind of, if they do have a sepsis or any kind of vasodilatory problem, and then we go filling them with more fluid, that could obviously lead to overload as well. So it's very important that they're recognised.
Yeah, so any patient that's not responding as you think it should, there's always scope for reassessment and altering your treatment plan based on what you're seeing.
Yes. Going to the kind of next part of the interview, we were going to talk a bit about dehydration. And we did have a question from a vet who asked, you know, how is it best to decide on rehydration plans and the period of time you decide to rehydrate that patient over?
So usually I replace dehydration over a 12 to 24 hour period. I don't have a hard and fast rule, and to be honest, you only really estimate a patient's dehydration status. So you're often providing a fluid prescription. For example, replace 5% dehydration over 12 hours, and then you reassess their fluid status. It's always a monitor and reassess process.
Okay. How do you decide on which fluid to give for a rehydration plan?
So to correct dehydration, you want a replacement fluid. So once again, LRSs usually go to about 90% of the time, but it definitely does change and can be influenced by a patient's underlying electrolyte status and acid base. For example, a severely alkalotic patient with low chloride, such as vomiting, I might use saline because that has a high chloride content. And some patients, such as those with severe hypernatremia, you might need to match the sodium in the blood so you don't cause rapid electrolyte changes.
Yeah, that's also something that I do cover in the webinar, and it's something that people can refer to if they feel they need a refresher or just want to know more about. How often do you recheck electrolytes on a patient receiving ongoing fluid therapy so that we don't miss, complications such as hypokalemia, which can come from fluids?
Yeah, once again, this is kind of a bit dependent on the patient and how critical they are. As a general rule, it's done once daily, but it could easily be done more depending on the patient's needs.
Okay, that's interesting because obviously you being working in a referral clinic, I'd probably dare say that in some GPs they're not tested every day, and this maybe should be highlighted as something that could be monitored so that they don't receive those complications. Do you agree?
Yeah, so monitoring the patient's electrolyte status does provide useful information, and you can titrate and adjust your fluid therapy so you optimize a patient's fluid therapy during the course of hospitalization.
Mm-hmm. Yeah, okay. Another question we had was regarding stabilizing patients before procedures. When to do this, when is it important, or when, is it okay to take a patient straight into surgery that maybe hasn't been able to be stabilised effectively?
So usually with these patients, at the very least, you want to correct the signs of cardiovascular shock before proceeding with something like an anaesthetic. Depending on the urgency of the patient to have their procedure performed, you want to correct as much of their dehydration as possible. Patients like gastrointestinal tract foreign bodies or pyometries are usually stable enough to replace their fluid deficits first before heading into surgery. An exception might be if they have a perforation and septic peritonitis. And so often with these, we want to correct their intravascular volume status and in a lesser part, their dehydration prior to surgery.
Yeah, and hopefully that was helpful to the person that asked. I want to start talking about some fluids that aren't our, stock standard LRS or 0.9%, things like that. A lot of people are interested in finding out kind of your opinion and when at times when you would use something like hypertonic salines or hypertonic solutions. Can you think of any times where you would opt for hypertonic saline?
Yeah, so I often use it to treat hypervolemic shock when I want to use a low volume resuscitation and minimize the risks of fluid overload. Additionally, I find it very useful in cases of things like head trauma, where I need to treat the cardiovascular shock, in addition to reducing the intracranial pressure, because I think I feel it helps treat two problems with one solution.
One thing I wanted to ask about hypertonic saline is, do you ever use it to treat a hemorrhaging patient? Because sort of in nurse school, we're taught that that's one of the reasons maybe not to use it, or if you do use it, then it can worsen a hemorrhage, because obviously the more fluid we put into the vasculature, the more with a bleed, the more blood the patient's going to lose. So do you ever use it to treat hemorrhage?
Yeah, so as I mentioned earlier, it is one of those times where one of the things I use to treat hypervolemic shock in hemorrhaging patients when I want that low volume resuscitation. Saline, you give a small volume and it provides a modest, somewhat gentle increase in the intravascular volume. So rather than if I give a very large fluid bolus, it causes a massive increase in intravascular volume over a very short period. Hypertonic saline produces a very much more modest increase in the intravascular volume and in a more gradual method.
Okay. What is the best solution to use for head trauma out of hypertonic saline and mannitol? Because I see some vets kind of think both are the same, or some question which should be used. Are there any differences there, or any times you choose one over the other?
Both are hypertonic fluids which will effectively reduce intracranial pressure. The two main differences are that mannitol also functions as a diuretic, so we want to ensure the patient is euvolemic prior to administration, as we may end up causing dehydration or further intravascular volume deficits. And hypertonic saline does obviously contain a large amount of sodium, so we don't want to give too much of it, or else we might adversely affect the blood electrolyte balance.
Okay, yeah, that's great. I actually think that answers my next question in part, because another person did ask what were the risks of using mannitol and the risks of not giving it when it was needed. So I actually think you've kind of answered that there.
Yeah. So look, I mean, I would say overall giving mannitol is a fairly low risk treatment, but there are a few things that we need to know, and probably the main one is the patient should be euvolemic, because if we make them hypervolemic, we might actually adversely affect the cerebral perfusion.
Yeah, of course. So yeah, I think that answers that really well, both questions. Is there ever an indication for using hypotonic fluids?
Patients that have things like hypernatremia, which is usually due to a free water deficit, we need to actually correct just purely their free water. And so we usually correct that using a solution such as glucose 5%, which is isotonic as it goes into the vein, but the glucose gets rapidly distributed through the body, and which relieves just the free water component of that fluid.
Okay, yeah, Of course, I do kind of mention that again in the webinar as well, and it was I couldn't find many indications whereby a vet would ask, a nurse to set up hypertonic solutions, but obviously, yeah, that would be one, a free water deficit. Well, Clifford, thank you. I think that's about all we have time for. That's been really useful, and I'm sure it will help, vets and nurses in both general practice and ECC. And I hope they do find it useful. So thanks again very much, and thank you to all the listeners.
Thanks very much for having me.
No problem. It's been an absolute pleasure. Thanks again, and I'll talk to you later. Bye now.